Someday I'm gonna be a star. I'll hire someone to drive my fancy car, and I'll buy my wife a new dress every week, and I'll buy a house where all my friends can't sleep. So what's your name?
Mark Kinzly.
Okay, so Mark, what was the first experience in harm reduction you had?
So back in 1990, I was living in New Haven, Connecticut, and at that time, New Haven had the highest rate of HIV amongst IV drug users per capita. And they had been doing an underground needle exchange there for a lot of years. Not a lot, but 2 or 3 years, based on what my mentor, many people's mentor, Dave purchased. They kind of followed his suit with what was going on in Tacoma, and they were doing an underground exchange in New Haven for IV drug users. And the AIDS epidemic was running rampant. I had been caught in the grips of addiction for a lot of years. And at that point, there started to be some rattling around them doing this crazy idea that we would give injection drug users clean injection equipment to curb the spread of HIV. I mean, people thought it was insane. And so what ended up happening, Shilo, was that underground needle exchange that was run by John Parker, Kaveh Kushnud, guys like Dominic Maldonado, who all worked for either the health department. Kaveh Kushnud was in graduate school at Yale University, and he started talking about coming above board so that Yale, in fact, could research this, and that the Department of Public Health for New Haven would take it over. They had a really strong AIDS division at that time, really good people like Elaine O'Keefe, who was really a backbone in a lot of the things that happened early on in New Haven, and oftentimes doesn't get the credit that is deserved around, bringing, I believe, the first legal needle exchange to the East Coast, in regards to it being under a health department. And so what happened is they were looking for outreach workers. And being that, an IV drug user, many of my friends, were dying, and they didn't have access to clean injection equipment. And I knew that I had access through a friend who was a diabetic, and so I applied for that job, never really thinking that I was going to get it, because the only experience I had was personal. I didn't know a ton about HIV other than what was coming from our community, and I applied for the job and got it. And so I was exposed initially to harm reduction through the media and through reading things from the New York Times about this crazy guy from Tacoma, Washington, who was setting up tables and exchanging stuff. And then this whole thing in New Haven started to occur, and it was magical, man. It was a time when we had guys, Black Panther by the name of George Edwards, who had incredible linkage to the community that was most infected and affected. We had really dedicated workers, like Dominic Maldonado, who wanted to make a difference here. And the way that it went down, man, is we got a pilot initiative from the legislature. We started needle exchange in New Haven. And it was at a time, Shilo, when Yale was doing doing the research on this and wanted to see the efficacy of it. And at that time, Shiloh, when we had to barcode every syringe that went out, and we picked sites in the city based on George's knowledge of where things were occurring, but also on a man that really made a huge difference in New Haven as far as this being accepted, a gentleman by the name of Nick Pastor, who was the chief of police at the time. And he was on board and understood the importance of this initiative. So you had the chief of police on board, you had the director of public health on board, and you had the state legislature on board. Like, we had some really powerful people, not to mention that Yale was going to be doing the research. It just brought some credibility. So much stuff that we didn't know. It was hit or miss, trial and error type things. And, there was some amazing programs going on in New York at that time, and they were exchanging, hundreds of thousands of syringes to the community, man. And there was research being done. This particular initiative that was being taken by Yale, the difference was this. We weren't doing just quantitative and qualitative data collection in regards to talking to participants, how many syringes in, how many syringes out. For the first time, what was going on is that we were, excuse me, we were testing every syringe that came in to the exchange, and we tested the syringes that prior to the needle exchange starting. We tested the syringes that were in shooting galleries that were in circulation for long periods of times, and there was upwards of 80% of the syringes that we tested back then from the shooting galleries were positive for HIV. And so the way that it was set up, Shiloh, in the beginning was that people would come in, we would give them a code name. At that time, the legislature would only max out, we could only give people 10 syringes and bring in 10 syringes. And we didn't know. We didn't know. We thought that it was groundbreaking. We certainly know today that that's really poor public health. We didn't know. And so what we found was people got codes, and when they came in, they got, 10 syringes. We barcoded each syringe, and every code name that was related to those 10 syringes that went out. When they brought them back, we had to write down the barcodes on if they were bringing back the same syringes, to see if people were sharing for the most part, and if they were the ones bringing back the syringes that had been taken out by them. But it also demonstrated what it looked like to make greater access to the drug using community around circulation, where in the beginning we saw syringes that were staying out there on the streets for like a week to 10 days. And then when we started doing exchanges, we saw these syringes coming back in a day or two. And anytime you can eliminate the effect of the number of days that syringes are out there, just based on need and availability, we started to see people, bringing in syringes a day after they used them, only using a syringe one time. And we almost immediately started to see a decrease in the number of syringes coming in infected. And so we saw some things. It wasn't people telling us this was what was going on. We were testing the syringes, and they weren't lying because it was scientific, data where the opponents to syringe exchange were saying, "Oh, you're getting people to say certain things," and so that was my initial. I mean, I kind of walked in through the back door in a sense that a former drug user or drug user at the time got on outreach program that deeply affected me personally. And so we we took that program and the success of it and branched it out to 5 other cities in Connecticut. and, and many of those are still running today.
So paint me a picture.
Sure.
So you have a syringe exchange, but does that just mean needles?
So, initially, Shilo, it was interesting because we really based a lot of what we did in regards to dissemination of harm reduction materials on what Dave Purchase was doing, what the Lower East Side Needle Exchange program was doing, places like that. So we handed out, and initially, quite honestly, we did not hand out cookers. Initially, what we handed out was uh, alcohol wipes and syringes and information. That was really what we started out with.
And what year was this?
This was 90.
90. Okay.
Yeah, 90, 91, right in that, right on the cusp of that.
Okay. And so you start in 90.
Yeah, at least above board. So the word legitimate obviously will bring up some stuff with people because I think the most successful programs that we have today would not be considered legitimate based on what we did in New Haven. But are probably the most successful infectious curbing programs in the world, and they're run by drug users.
Yeah. So this is in 91. Okay, so start walking me through, like you grow into, you said 5 cities or 5 counties?
5 cities. And it was all based on the infection rates, which wasn't surprising. The cities that were picked, pretty much, we had Hartford. They were the major cities in the state. Hartford, Bridgeport, New Haven, Willimantic, which was a small community, but had a really high percentage of IV drug users, and Stamford.
And so you were only working with injection drug users, weren't working with smokers yet?
That's correct. That's correct.
Okay. And so did you guys ever start working with smokers?
We did. My own personal history around this, what ended up happening, Shilo, was because of the deaths that we were going to funerals, 2 or 3 funerals a week, Shilo, where, like you couldn't watch it. Like we were burning out, like really quickly. And I got into a place where I started to refuse going to funerals. I couldn't watch people die anymore. It was horrific. And I actually left New Haven and went to New Hampshire to be their state outreach worker, and eventually was literally escorted to the state line by the state police for doing underground exchanges. The state's largest newspaper, the Manchester Union Leader, actually put a caricature of me with a hobo stick and a suitcase, and on the suitcase it said, "Have needles, will travel." And they kicked me out of the state. At that time, I went back to Bridgeport, Connecticut. It was about a year. And started running the Bridgeport, Connecticut Needle Exchange. It's the largest city in Connecticut. At one time was named the most violent small city in America, and it was the first city in the country to file for bankruptcy. There was nothing in Bridgeport but drugs. It was horrific. And so kind of increasing the opportunity to do syringe exchange and a larger community, one of the things, and this is how we start to work with smokers. I know from my own personal experience that I probably put myself at greater, if not as great, maybe greater risk in the years that I was smoking crack cocaine as opposed to shooting, because I would do things very differently when it came to that particular substance. We were at a training. My friend Tony Gibbons and I were at a statewide training that was run by the HIV division, and the guy who was the head overseeing all the syringe exchanges in the state, was doing a presentation. And we were on the streets every day. And so we're in this presentation, and he was talking about needle exchange. And we know, by this point, we were giving cookers and cotton and, really giving out really good harm reduction materials and making a big difference in the community. And the last statement that he said was, but when it comes to the crack using community, you can't do anything with them. They're just crazy. And the hair on my neck stood up, and the hair on Tony's neck stood up. And on our drive back to Bridgeport that day, we decided to do something about that. And so we started looking into, just like we did with needle exchange, Shilo, we started looking into the community and asking, what do you guys need? What do you want in regards to staying safer? What is it? And it started out with an informational pamphlet initially that was, it was developed by us. This is like 90, at the end of 92, early 93. We developed an informational pamphlet that had safer smoking techniques, the risk around, sex and sharing equipment, a lot of the same information that we would do for needle exchange. Rod Sorge, who was running a crack users meeting in New York City at that time, we started talking back and forth and what people needed. And I'll never forget it, Shai. The first day that we went out just to hand out informational pamphlets doing outreach, right? People that were using crack said to us, oh, you guys finally figured out we were here. And I knew, man, like...
And what year is this?
This was 93. And I knew, man, that because of my own personal experience and what I had seen in the community, man, like, it was horrific. One of the things about the New Haven program was that Kaveh Kushner was doing a really in-depth interview with each participant, right? And when we first started doing the interviews, you would ask what drugs you were doing, and across the board, it was people were using heroin, right? And or injectable opiates. And we would also ask, do you do other drugs? And at that time in 90, like, all the injection drug users were saying, like, crack, no, those people are crazy. I would never do that. He did a 6-month follow-up. This was part of his dissertation. Did a 6-month follow-up, Shilo. And within 6 months, we probably saw a 50% to 70% increase in just injectors also doing crack. So there was that whole dynamic that was going on when we went to Bridgeport.
And so do you think there was, I know that people talk about this, that drug bigotry between the two groups.
Sure.
And do you think that had anything to do with the syringe exchange not doing it? Or do you think it was another kind of bigotry?
I think it's multifaceted. It's a really good question, Chai, because here's the thing, right? So there's no doubt there's a hierarchy in the drug using community. I shoot dope. I would never smoke crack. Oh, I smoke crack. I would never shoot dope. There's that whole bigotry, like you said, that goes on. And what we started to see also, Shilo, is that there was clear separation at one point between a shooting gallery and a crack house. I mean, they were separate entities. Within a year's time, because of the war on drugs and, really increased focus on busting people, because we would be able to stop the epidemic if we arrested everybody, right? What we started to see was crack users and injectors started to congregate in the same residence. And so there was a crossover and a crossover in risk behaviors. People that were, historically just injectors started smoking crack because of the nature of what crack does and the shortage of its half-life, one of the big deals, as you know, is sex trade, right? And what we started to see was, because there was such a high number of people that were HIV positive that were injectors, now we're having sex with individuals that were just smokers. And so we started to see an increase in people that were non-injectors becoming infected. And so it was, it was an interesting time. And it was driven, Shilo, by the information of what, in focus groups, what the community wanted and needed to stay safer. And we started handing out stems, the instrument that people smoke crack out of.
And what year was this?
So this was 93. It wasn't until December of 93. So 94 we called it, before we really started sending out the kits as they became.
And what did you have in those kits?
So these kits, what the crack using community wanted, first of all, they wanted stems, right? And they wanted stems because that community was not any different than any other community that's using drugs, and they will share equipment if there's lack of availability, right? Yeah. And so the risk factor around, if you're not doing anything else other than smoking crack, the risk factor is broken glass stems, burned lips, sex industry, oral sex transmission, passing of the stems with broken blood on it, hepatitis. We sincerely believe that at that time, and still do, that there's a risk factor. And so we started giving everybody their own stem. We started giving them mouthpieces, what we called mouthpieces. And initially, Shilo, those mouthpieces were a matchstick and a rubber band that was wrapped around the stem, because that's what we historically had used in the crack using community. Mm-hmm. What we realized is that after repeated heating, those rubber bands continuously broke, and eventually people would be left with just a glass stem. Mm-hmm. One of the users came to us one day with a spark plug cover, and said, this is what I use. And what it did was it gave the idea around having something that was not going to allow the lips to be burned, but also give protection to the stem so it wouldn't break. And so we also put Joy in there, the screen that is often used for the crack sitting on, and that is preferred by many, many crack users, at least on the East Coast. I believe on the West Coast as well. Mm-hmm.
So you gave those out at the Needle Exchange?
Correct. We did.
So really, we're talking the first smoker injector program in the country.
Correct, in Bridgeport.
Correct. And so, what was this like? What was it like merging those two communities together?
It's a really good question. So here's the thing. One of the ideas that was in Bridgeport, Shilo, that has been really important, and I believe in really good harm reduction programs, and that was, first of all, the immediate need to curb any negative, the negative consequences that could be curbed, right? We needed to make sure that the community that we were serving was comfortable with this, both the injectors and the crack users, right? Yeah. And they were, and so, it's interesting because there was a number of things that happened in that time between those communities. They, first of all, had become much more one than they used to be. And, what we did in Bridgeport was kind of special, man. Like, we stopped going just into the housing projects to do outreach work. And part of the reason for that is anybody who lived in public housing at that time were hesitant to come to the van, because if you're in public housing, you're coming to the van that is solely identified as a place where you go get syringes, you're at risk for being homeless, right? So we started to put other things on that ban, like food, like doing testing, like getting an OBGYN, like getting medical people on there, so that not only the drug using community came to that ban, but the community came to that ban. And what started to happen was the stigma around that ban started to dissipate.
Yeah.
That people came to that ban for a lot of different reasons.
And so we're talking at this point 98?
So by the time when pipes were in stems,
Yeah.
so 95, 96,
Okay.
yeah, when really it started to kick in, Shilo.
And what are we talking in like numbers here? Are we talking like thousands, hundreds?
So let me back up a little bit with the stems.
Okay.
Is that time, because it was run by the health department, right? There was a real concern that, because at that time the syringes were covered under the paraphernalia protection, but the stems were not, right? So, after talking to a number of people, people were coming off the ban, quite honestly, Shilo, and some people got arrested for the stems. So what started to occur to us was we needed to figure out a way to get the materials and information into the community, not just through the ban, or we could disseminate some of the materials on a ban so that there was a connection with us on a regular basis, right? For food, services, whatever. But other resources like STEMs could be done secondarily through the gatekeepers of crack houses, places like that, so that the users would get them, right? But they didn't have to come off the ban. It was still the thing that we deal with in many programs today in regards to many people were much more worried about the funding resources that were coming into the agency than oftentimes the prevention we were doing. And that's not changed, Shilo.
Do you think the drug users' voices aren't being heard?
Oh, there's no question about it.
Yeah.
Listen, so the most stigmatized community in the world are probably drug users. Most misunderstood. People get more misinformation about drug users than any other community that I'm aware of. The risks just around using drugs for your own freedom is enormous, right? So, yeah, they were not being heard the way they wanted to be heard until we started to do things in smaller settings, like focus groups with just drug users to talk about stuff. The nice thing about the band in Bridgeport, man, that band, it was an old bookmobile. You could hold 12 people, So, like, we had focus groups on the band. It was great.
Yeah.
Come to where people live and where they function. And did it start to chip away at drug users' voices being heard? It did. We are nowhere close to where we need to be. There's places, as you're aware of, like North Carolina, like Washington, like New York City and San Francisco, who have really strong drug users' voices. Let us never, ever, ever forget, Shilo, how needle exchange, how harm reduction started. It did not start by scientists, researchers, public health officials. It started by drug users who wanted access to simple equipment to stop the spread of hepatitis at that time. It was driven by drug users. The good programs today, the ones who reach the masses, are run and operated and infiltrate other communities, but the drug users are the ones that are going to make the difference. Whether it's overdose or HIV prevention, Shilo. I mean, we have huge documentation of that. There's more research around what needs to be done, and yet it's still not being funded appropriately. Drug users are still not heard appropriately.
Why do you think that is?
Oh, I think there's a lot of reasons, but I think that the war on drugs has pigeonholed messaging, first of all, okay? Around how the message around what drug use is, what it looks like. You know, we've talked about this in regards to the color of your skin, how you get your drugs and how you use your drugs, right? Will dictate oftentimes how you get treated, right? So, whether that's in a drug use or just social services altogether. Now, if you're a person who's in poverty, person of color, or of maybe a different sexual orientation than mainstream society is used to, and a drug user, not only are they not heard, but mainstream society doesn't want to hear them. They're afraid of them. Because, you know, we've gotten to a place in our society, Shilo, that guess what? That's your mother, your sister, your brother, your cousin, your aunt, your uncle, your police chief. It's now everybody in one form or another could be regarded in some sense or another as a drug user in some way, right? Like under the definition that a drug is any small, product that changes the mind, body, or both, like caffeine. I mean, everybody uses some kind of mood or mind altering substance. It's much more deadly than it's ever been. And part of that could have been curbed dramatically had resources and appropriate programs been started. You know,
What do you think those programs would be?
where or what?
What?
Well, I mean, I think things like secondary exchanges that disperse materials and information into the community most affected, like let me give it to you this way. I think it may be easier in the larger cities for drug users to have access to certain things in a lot of ways. There's more resources in regards to that. But look at rural communities that have very limited voices, very limited resources. If you have a group of people that come together to carry a really solid, congruent message around health of, drug users, people that they're in the community with, and that they have the materials and information to give to people when they come to them. I think that's one thing. We need to look at our outreach in rural areas, like rural Washington State, rural Texas, places that don't have any resources, that are now through drug user run organizations like People's Harm Reduction Alliance, right? Like, Homeless Youth Alliance, like Vocal, places that are like, the Users Union here in North Carolina that are making a larger difference than many public health officials ever made in a short period of time with no funding or limited funding.
As that program became successful, right?
Right.
The end question is it existed there today, and has it grown to a statewide project with smokers?
It's a great question. In regards to smokers, individual programs do safer smoking initiatives. Has it become a solid? We were never taken serious in Bridgeport around safer smoking in the state of Connecticut. I mean, they called us crazy, Shilo. Other parts of the country took some of that on and built it, that are running huge safer smoking initiatives in their community and seeing results of that.
Yeah.
Seeing the results of people getting healthier. Mm-hmm. And so in Connecticut, no, it didn't really get larger. In fact, Bridgeport has just recently been taken over by a non-public health agency, which me personally at this point believe is a really positive thing, for a number of reasons. They're not tied to all those legislative, handcuffs. And the other thing is that a lot of these organizations in the community do a lot of different things, like substitution therapy, methadone and Suboxone, like, things that the health departments don't necessarily do. They also do the testing and counseling and all that stuff. It's much more widely accessible. Now, the programs have become much smaller because, quite honestly, they were run poorly, and people started letting individuals that didn't understand or weren't willing to understand the drug using community and their needs. Like, outreach used to consist of actually going out in the community. Outreach now consists of, if you show up at my building at these particular hours, we'll let you get some stuff. If you're not really high, if you're not holding, these are all barriers that we've put into place. Whereas in drug user run organizations, those things don't occur.
Do you think that drug users, in your experience, were treated different than, let's say, people after condoms? Because drug users wanted these supplies where you have to convince someone to put a condom on?
It's a really good question. So we saw the massive distribution of condoms, right?
Mm-hmm.
And still, we had to convince people the importance of using them that may be at risk, right? I mean, we literally had to, every week, show up at the same place to do the same training to the same people, and we're getting the same results. Like, some people were going to use them, and some people weren't. With the drug using community, there was so much need and want around having safer equipment that it didn't have to be marketed. We did limited training because, by the way, when you're doing drug user initiatives, the drug users are the experts. They already know how to do most of the stuff to stay safe. They need the materials to stay safe and access to the resources, like naloxone, like safer smoking kits, like syringes. Like, they already knew what to do for the most part. They didn't have access.
Yeah. So the smoking, when did that end, or did that end?
So they still do limited safer smoking initiatives in the cities in Bridgeport, in Connecticut. I left to work at Yale University in 1998, right after, it was 99 actually, 1999, to actually do, hopefully get some initiatives going through the Center for Interdisciplinary Research on AIDS, which had money to do not only research, but we were told that they were going to be able to disseminate not only information back to the community, but also resources, right? That did not pan out like we were told it was going to pan out.
What happened?
Well, I think that, like a number of educational institutions are more concerned and worried about their whole publish or perish initiatives than they are the people that they do the research on. And I'm not saying across the board, but I will tell you that many of the research projects that go on rarely have drug user input in the research that's being done, and they almost never get the information that had been pulled together and evaluated back into the community so that the community could change whatever behaviors that were going on in regards to risk, right? So there are a number of people that in academic institutions that did the yeoman's work of going out into the community, see people that understood the community, drug users, would go out in the community and get all the information. And quite honestly, once their either their ability to access information or the university's no more need for them to work there to access the information, because academics can't get to the people in the places that we can get to. They can't do it. And I think, so the other thing around drug users are often kicked to the curb oftentimes when they were the most important or some of the most important people in some of the greatest research ever done. They are treated just like either their former selves as drug users or their current selves as drug users. They're discarded.
Yeah.
And I don't want to put a blanket statement on that, Shilo, but if you look at the history of what's been done in a lot of academic settings, that's exactly what's happened.
So working at Yale, it sounds like you kind of get your eyes opened.
Mm-hmm.
Kind of the situation happens. When do you leave?
So one of the things that started to happen, we did some really good research, some really powerful stuff around syringe access, use and discard, really good, strong stuff. My history is that I, used drugs for many years, got clean for many years, got injected accidentally with a infected syringe during an overdose episode, ended up relapsing and starting to use again, and was chaotic in my use, quite honestly. So this did not per se go against what I thought the institution should do. I mean, I certainly need to own what I need to own in this, and I did some things that were really unprofessional. And some people in that institution looked out for me because I probably really could have, gotten in a lot of trouble. However, we got discarded. Not just myself. There was a number of us that got discarded for a number of reasons because we weren't needed like we were. I left Yale in 2008, so I was there a decade. And some amazing things occurred in there. Some really powerful stuff, some absolutely tragic things happened there.
Yeah. And so where did you go from there?
So my using, as I stated, was chaotic. I went to, I helped out, I was working at a program at Hartford that did outreach and needle exchange and stuff like that. I eventually ended up going to Boston, Massachusetts, and running a harm reduction center out of, it's called the Roxbury Community Healthcare Center. It's no longer there.
Yeah.
And it was right in the middle of the hood. It really provided really good services to a lot of people.
Yeah.
It was really poorly run in regards to financials, and it met its unfortunate death in a community that desperately needs it.
Yeah.
And then, eventually, and I think it's important that, in 97, we started to deal with Dan Big around the overdose stuff. That started to become a bigger issue. We got the first overdose stuff going in Connecticut.
What did that feel like, handing out your first Narcan?
Using it or handing it out?
Handing it out.
By this time, Shilo, I had been, in 97, man, I had seen way too many deaths around overdoses, man. And, there was people like Dan Big and some others that were really putting their freedom on the line to give people really easy medication to save lives. So the feeling that I got was, we're going to be called crazy. I know we're not. Just like we were called crazy with syringes, just like we were called crazy with stem. I knew we weren't crazy, Shilo. I knew that we could make a difference. I knew it. I felt great pride in the opportunity to have a chance to give people something else that could help them stay safe. It was powerful. It was powerful when we did our first reversal. It was powerful when we heard about our first reversal. I was still in Bridgeport when we heard about that. We got naloxone from the Chicago Recovery Alliance, and we didn't know exactly what we were doing, but we learned enough from people, and we knew that people's lives could be saved. I mean, why wouldn't you hand it out everywhere? And again, by '96, OxyContin had come on board, and that changed that whole dynamic. Doing work when we ended up getting to Yale, doing work in Washington County, Maine, which had the highest overdose rate in the United States per capita. And it was almost all OxyContin and prescription medications. And first of all, they didn't have access to substitution therapy, methadone. They had to drive 5 hours one way to get methadone. Yeah. They were caught out. And so, giving my first kit was really powerful for me, man. Using it was really powerful. Having it used on me was really powerful. When I relapsed, not being accessible to my friend when he died from an overdose in my office at Yale was really powerful. It changed like a lot of things, man, like how we did this. And the importance of giving people the opportunity to get hope again, man, and not withholding something that is so important and so benign. And the only reason we don't hand it out more readily is because people have this idea that 5 dead drug addicts are more important than 10 drug addicts being saved, even if they don't stop using, man. That's a quote by the governor of Texas. Who, come on, man, we have life-saving medication and resources, and you're not going to hand it out because you think the people that need it are bad people. Yeah. I mean, these are people, man, even if you look at illicit drug users as people that may not have the moral fabric or fiber that you have in your own personal life, man. Take a look at your neighborhood, man. Everybody's dying from this goddamn thing, man. It's sick, man. And the reality of it is who's going to turn this around? Who's going to drive the curbing of the overdose epidemic? Drug users. We're going to learn everything we need to know about curbing this thing by drug users, because they demonstrate it daily on how to save lives, man. First responders, cool. They're not the ones that are often there when an overdose occurs, man.
Do you think drug users are experts in their community?
Oh, they're the experts in their community. They're the experts. They just need the resources to do some really good stuff.
Do you think harm reduction groups and researchers and doctors take credit for some of their work?
I think harm reductionists, researchers, and many of the medical profession takes all the credit for the work that drug users do. And then there's the amazing researchers, there's the amazing harm reduction providers, and then there's the amazing medical people, the doctors that are changing the face of what this looks like for drug users to have access to medical care, to have access to life-saving medications. Heroes like Alex Wally and Philip Coffin and researchers like Alex Kroll and Robert Heimer and people that changed the face of what this looked like. But the ones that are going to make the difference, Shilo, are the drug users.
Yeah.
It's like, this is not rocket science, man. It's just not rocket science. And yet we want to continue to add paperwork and barriers to the simplest of the interventions.
Do you think that one of the most powerful things you've done is builds people's self-respect and builds people's confidence?
You know, I'll tell you, it's interesting, man. I think, you know, it's just like when we go into communities, you know, I'll just kind of go back a little bit here. I remember pulling up in a community in New Haven, man, and because we were from Yale, and we pulled up in that community, and we were gonna, you know, we acted like we had everything that they wanted, and we never even asked that community if they wanted us there. And one of the things that people have to realize is that the drug using community is no different than any other community. They have figured out almost all the things that they need to survive on a daily basis, right? Like, we are not the rescuers. The heroes in this, man, the true changers are the people that access these resources and help other people with it. We are the conduit, man. Edith Springer, my hero, would say all the time, man, we are agents to change. We are not the change. We are agents, right? Like, we get things to people and work with them around it. They're the individuals who make the change, not us.
Yeah.
Not us, Shilo.
What do you think was one of your biggest successes in your work?
The work?
Yeah.
I don't know, man. I hope that I've been able to cross some barriers between academia, the street, and users and medical and all that thing, and get people to understand a little bit more from all those areas. I think the greatest success was, quite honestly, was the opportunity to work with the most intelligent, resourceful, misunderstood people. That, for me, the greatest joy that I get, man, is in the eyes of another person, some people in the recovery process that chose that path, where their lives changed. Some people that had resources and got clean injection equipment and their lives changed. Some people that got a meth pipe or a crack pipe and their lives changed for that day in regards to what they could do to stay safer. I think I've had maybe the most important work that we've done has been the opportunity to get it into the community that can greatest use it. And get out of the way.
What do you think? What do you think your biggest failure was?
I think my biggest failure, personally or professionally?
Both.
So I think my biggest failure personally is that I personally am a much better harm reductionist when I'm not using, okay? In regards to what I can bring to the table, I can do really good stuff even when I'm using, but personally, man, I think I could have done a lot more in regards to pushing legislatively and things like that. I just didn't have the ability to do it at the time.
Mm-hmm.
Harm reduction has cost me professionally, because of the misunderstanding of the people that I probably worked for, has cost me careers because of because of a reoccurrence of what they call a disease. And even when I got clean again, man, like people didn't really, there's a lot of people in the movement that really cared, but the institutions that we had a part in changing the way things are done, once they used us up and didn't need us anymore, man. Look, kind of like just turned a blind eye to anything that we were doing, and so professionally, man, I lost really good opportunities, not only because of my own personal drug use, but professionally because I lost a lot of opportunities, man.
Yeah.
That I think I could have made a greater difference, Shilo. I'm convinced I could have made more of a difference, man.
What is something? Is there anything that I haven't asked that you think is important to tell?
So I think the one thing is that we're just breaking ground on the ability of what harm reduction looks like in this country and what we can do. And in regards to laws, in regards to access to services and resources, I think we're just now understanding what that looks like. And as we further educate the powers to be around what's needed and what is useful, I think we're going to see huge successes with infectious disease, with overdoses, with a number of medical issues. But I also think we're going to start to see things like housing being provided more readily, things that are real harm reduction tools like getting people safe housing. I think if we would do this interview a year from now, Shilo, I think that we would maybe even have a different perspective on what needs to be asked and what needs to be said.
Yeah. I'm going to ask you a couple more questions, mainly because I think you're one of my mentors, and you're someone who I think sees the harm reduction world in a national sense, not necessarily in a local sense. What do you think is lacking? And how do you think we get there?
Well, it's going to sound kind of like, oh, another one of those guys that needs money. But we need funding to do really good, appropriate services. We need development of infrastructure within agencies, like technical assistance of people that have been doing this for a long time, teaching other people how to do this.
Yeah.
I think that's really important, man. And, people that have knowledge around what is effective and what's not. Like, my God, we're still doing one-for-one exchanges in parts of this country. I mean, how insane.
Yeah.
So.
Do you think smokers have been left behind?
So here's my deal with this so I'm going to talk about the crack user. Let's say that crack smoker in particular from, what I've witnessed personally and professionally is that although now it's a little bit shifted, I think that the smokers are even more stigmatized in a lot of ways. And the ability, whether you do really, really scientific evidence-based research to prove what we had to prove with needle exchange or not, that crack smokers have had more misinformation written about them than any other group of people, have had much greater lack of access to resources. People that want to get clean and sober from crack can't go to treatment because crack's not addictive. And you know, all these things, terms like crack babies still are in our society, even though we know that there's no such thing per se. So I think that the smokers have been left behind, not only in resources, but decision making. Shilo,
Yeah.
bring up crystal methamphetamine users in many parts of this country, and people cringe at the point of even discussing health initiatives with them. They cringe at it. And so what society deems to be crazy people need to be crazy and go do crazy work to get the message out.
So here's a question, and it's a question I've actually always wanted to ask you. There's been a lot of research done on drug use and drug use.
Correct.
Do you think we have done enough? Do you think we need more, and where do we need it, if we need more?
Well, we certainly need more research in regards to the scientific evidence related to people sharing stems, you know, all that kind of stuff. What's transmitted, what's not transmitted. You know, what are some of the safer things that we need to research to find out what is safer?
Yeah.
You know, is it tinfoil or is it, you know, who knows, whatever, right? So I think there's many areas of drug use that are over-researched and probably don't ever need to be researched again. Even though the drug culture and community changes pretty rapidly around some things.
Yeah.
But I also, here's the other thing with the research, right? The research is often very behind the times of what's actually going on at the time, right?
Yeah.
So by the time really good research is done on the crack smoking community or even the IV drug using community, the drug using community has almost always figured out how to be safer around those things.
Yeah.
So, you know, there's areas where I think we've over-researched and there's areas where I think we've under-researched.
So what can a drug user or drug using community do to engage a researcher in a way that they get real services and real quality for their community?
So, pie in the sky?
Yeah, I mean, what should drug users be demanding?
Demanding that they have a seat at the table when studies are developed.
Okay.
Okay, I think it's really important. And I say this, and people will disagree with this. I'm not talking about former drug users. I'm talking about people that are actively using.
Yeah.
Because if we don't have a handle on the pulse of what's going on right now, again, the research will be outdated, right?
Yeah.
We need to have a pulse. So drug users need to be at the table all the way from providing services to being on boards of agencies to being part of research development and what's needed and what questions look like and why they look like that, to running, did I say running research projects, okay, to writing and publishing and being recognized within the academic community as someone who was important in the in the collection of the information. Drug users are often left off of academic papers.
Yeah.
Often.
Yeah. So is there anything else you'd like to say?
No, I don't even know what I really said, Shilo. I know I got a little emotional, and so, you know, I think as many people have had a love-hate relationship with a lot of what has happened over the last 30 years,
Mm-hmm.
25, 6 years in harm reduction, right? And yet, I think we were making significant changes, man, in a lot of ways. And I think there's an opportunity for us to make more, okay? So I'm not sure what I said. I don't know if it was even informational, man. I don't know if it talked about the history enough. I don't know. I know that we need to know where we came from. We need to know what's been done. We need to know who did them. We need to know that guys like Dave Purchase and Rod Sorge and Edith Springer and Shilo Murphys and Dan Biggs and Alan Clares and all these people, man, and whoever comes next, Shilo. Our biggest job is to teach, right? Others how to do this. And to stay focused on doing it, man. This isn't easy work.
No, but it's a work of love.
It is.
Well, thank you so much.
Thank you, brother.
If I ever leave this world alive, well, thank you for the things you did in my life. If I ever leave this world alive, I'll come back down and sit beside your feet tonight. Wherever I am, you'll always be more than just a memory. If I ever leave this world alive, if I ever leave this world alive, I'll take on all the sadness that I left behind. If I ever leave this world alive, the madness that you feel will soon subside. So in a word, don't shed a tear. I'll be here when it all gets weird.